I'm Dr. Elise Day, Professor of Urology, and I'd like to help you understand what all people with recurrent UTI would like to know: how to prevent the next one. This video is for educational purposes only, and please bring what you learn from it back to your healthcare team to understand how it applies to your medical care. Most practitioners know how to treat a UTI, but it's optimal care when UTIs can be avoided. There are good strategies to prevent UTI. First and foremost, if we can identify a cause of UTI, it should be addressed. But even if we have not found an easily treatable cause such as a stone, there is pretty good data on the following. Postmenopausal women benefit from vaginal estrogen. Younger women with hormonal factors may also benefit, such as nursing mothers. A high-quality cranberry supplement, such as GenaMD, may help, or your doctor may recommend methenamine and vitamin C. There is good data on both. It may help to increase water to 2 or 3 liters daily to flush out bacteria, urinate after intercourse, and to use a bidet if you have trouble with bowel issues such as diarrhea. You should steer clear of douching, antibacterial soaps, and vaginal irritants. Prevent constipation, and do not blame yourself for hygiene issues, as UTIs can affect anyone. Aim to empty your bladder at least 5 times a day to keep the urinary tract clear. There is a lot of information out there about estrogen, so I'd like to talk about that specifically. Our major societies, the American Urological Association, Canadian Urological Association, and SUFU, have put out guidelines on recurrent, uncomplicated UTIs in women. Thanks to these amazing people, clearly supporting the use of cranberry, voiding changes in water intake, methenamine, and vaginal estrogen in peri- and postmenopausal women, as long as there are no clear reasons to avoid it. More of our major societies, the American Urological Association, SUFU, and the American Urogynecologic Society, and these amazing people confirm vaginal estrogen as standard of care in women with recurrent urinary tract infections in the Guidelines on Genitourinary Syndrome of Menopause. This guideline finally assures us that vaginal estrogen does not cause breast cancer or endometrial cancer. The FDA this year removed the black box warning with misinformation about these risks. For people who have a history of breast cancer, the decision-making is slightly more complex, but not an absolute no. Vaginal estrogen cream has been shown in 30 randomized clinical trials to reduce frequency of recurrent UTI in postmenopausal women. Although systemic levels of estradiol may increase briefly and to a smaller degree after starting local low-dose vaginal estrogen, theoretically via the atrophic vaginal epithelium, the levels return to menopausal after 12 weeks. The applicator shows you how to measure 1 to 2 grams. A gram is about the size of a raisin or a pistachio. But most of my patients find the applicator cumbersome to clean, and they prefer to use their finger to insert the cream vaginally, then rub it onto the vaginal, vulvar, and clitoral tissues, the same way they apply skin cream to their face. If the cream is not right for you, there are also inserts and rings. Some of my patients don't tolerate the propylene glycol base, so I send them to the compound pharmacy where it can be mixed in a hypoallergenic base. Some women do better with the ring. That just needs to be changed every 3 months. This slide highlights a pivotal Danish study on vaginal estrogen use and breast cancer recurrence among over 8,000 women with early-stage estrogen receptor-positive breast cancer. Key findings include that local estrogen use did not increase cancer recurrence, including in women taking tamoxifen, which is an estrogen blocker. However, use of vaginal estrogen in combination with aromatase inhibitors, medications which prevent natural creation of estrogen and thereby starve hormone-sensitive breast cancer cells, was associated with a 39% higher risk of increased breast cancer recurrence than women not exposed. So if you have a history of breast cancer, use of vaginal estrogen is not absolutely prohibited, but discussing this and future data with your providers should help you make the right decision for you. It has been published that for women with a history of endometrial, ovarian, or cervical cancer, vaginal estrogen is considered safe. If you have this history, discuss the most up-to-date data with your providers. A very large study called the Women's Health Initiative Observational Study showed that risk of cardiovascular events is not increased by using vaginal estrogen, nor is the risk of stroke. Lastly, the benefits may go beyond just preventing the next annoying UTI. We recently published that in women with recurrent UTIs of all ages, receiving a vaginal estrogen prescription is associated with fewer serious adverse events such as sepsis, hospital admission, and death. This study was performed in the very large Epic Electronic Health Cosmos Research Database. It is possible that the estrogen prescription was simply a marker of more conscientious doctors, but we need to take this data seriously. There is no question that UTIs can be dangerous. I personally offer vaginal estrogen to all women with recurrent UTI and hormonal reasons to have low vaginal estrogen. In younger women, this includes nursing women, women on oral contraceptives, women on hormonal manipulation for endometriosis, and also for transgender health. So what other options are out there for people of all genders? The Wiki Guidelines reviewed the data on common preventatives. The data on cranberry products containing proanthocyanidin and methenamine, which is a urinary antiseptic rather than antibiotic, came through strong here. Cranberry is a great option. Let's talk about cranberry. Based on a systematic review of 50 trials with almost 9,000 participants, cranberry products were found effective, but the data was inconsistent. Possibly because not all cranberry products are the same. The processing method affects potency and health benefits with variations in efficacy even among products with similar proanthocyanidin content. Those are the PACs. In this study, 4 independent labs looked at 53 products and found only 3 actually had 36 milligrams of PACs, the levels needed to prevent UTI, despite labeling otherwise. In high-quality cranberry supplements, 36 milligrams of soluble PACs are present in order to achieve the level of anti-adhesion activity that sticks to the bacteria and prevents them from sticking to you. Cranberry juice does not get you there. Effectiveness in the products out there can vary widely. Some may have anti-adhesion as low as 0%. I use JennaMD by Solve Wellness in my patients, and beyond an annual meal with their team, I don't receive payment for recommending it. I use it because it has saved my patients a great deal of hardship over the years. There are other high-quality products out there. This is not the only one, but you have to do your research. Now let's talk about other options for UTI prevention. There's good data on methenamine salts, which convert to formaldehyde in acidic urine, acting as non-specific antiseptic. They have to be taken with vitamin C and should be stopped for a bit in the presence of certain antibiotics to prevent urine precipitates. Insurance usually pays for this prescription option. What about other oral treatments for urinary infections? Ascorbic acid, vitamin C, may acidify urine to deter bacterial growth, but evidence on effectiveness is mixed. D-mannose is a sugar. The theory is that it prevents bacterial adherence to the lining of the bladder and urethra. I have not seen high-quality data that it works, but occasionally I have a patient who swears it has worked for them, in which case we just have them continue. Eucora is very popular. Its 3-step process includes D-mannose, vitamin C, and a good bacteria called lactobacillus. I have not seen randomized data, but again, I do have patients who say it's helped, and in those patients, we continue as long as it's working. Vaccines and immune-based treatments are not yet available in the United States, but show promise in some areas of the globe. The 2 with the strongest evidence are Urovaxum, a daily oral capsule, and Uromune, a daily sublingual spray, both shown in clinical trials to cut UTI recurrence roughly in half. Urovaxum is available in Europe, Asia, and Latin America, while Uromune can be obtained in Spain, the UK, and Australia. If you would like to see if there are scientific trials underway in the USA, go to clinicaltrials.gov and search for urinary tract infection vaccine. Probiotics have shown some promise in individual trials. The idea here is the good bacteria restore your normal flora and prevent the more aggressive bacteria from taking over. For example, this product uses Lactobacillus rhamnosus and Lactobacillus reuteri. In a 2015 Cochrane review, which is a very well-respected authority on big questions in the literature, analyzing data from 9 trials focused on Lactobacillus species, they concluded the data was too limited to determine whether probiotics prevent UTI, that more research is needed, and that probiotics are generally safe and may offer other health benefits. This slide is important. It is very tempting for both people with UTI and their providers taking care of them to just start people on a daily antibiotic. I only do this about once a year in my practice, really when nothing else is working, and only after asking for input from my colleagues in infectious disease. In most cases, the benefits do not outweigh the risk. So, how do we prevent urinary tract infection in people with indwelling catheters? First of all, not all catheters are the same. Some have nice soft material and a shorter tip beyond the balloon, and it is less likely to irritate the bladder wall, create clot that certain bacteria like to stick to. Indwelling catheters should be changed every 4 weeks to prevent debris formation and to reduce UTIs. The duet catheter has a smooth balloon on the tip, and the location of the drainage port may allow for better drainage, but this has not been shown in randomized data on patients with infections. Likewise, the newer Flume catheter also has a very gentle tip and is designed to reduce irritation and improve comfort. We don't have clear data on the benefits of catheter type, but we do know that some people really benefit from having a catheter to keep the bladder empty, protect their kidneys, and reduce the risk of UTI, even though the catheter itself introduces some risk. It's a balance. In many situations, clean intermittent catheterization can be used. In this management, a catheter can be self-inserted in and out to drain a few times a day when needed, rather than leaving a catheter indwelling with a balloon, thereby reducing the risk of biofilm and bacterial colonization. Many types of intermittent straight casts exist. If you or a loved one are dealing with UTIs, there is a light at the end of the tunnel. It's really helpful to understand more about preventing UTI. Usually working with your healthcare team, you can find a way to prevent them, reducing frequency and improving quality of life. In this video series, we also explore causes of UTI, help you understand testing, highlighting how healthcare professionals diagnose UTIs, and discuss what might feel like a UTI in the setting of negative cultures. By the end, you'll have a pretty good understanding of UTIs and what to discuss with your healthcare team to find out what might help you. Check out our videos, our website, our YouTube channel at Facing Pelvic Pain, and share and subscribe. I hope this information was helpful, and thank you for your attention.